So friends, when to suspect a COVID patient? If we come in contact with a COVID patient, usually we get contract infection and mean time of incubation period is 4 to 5 days, but maximal is 14 days. However, 98% contract infection within 11 days. So if 11 days had passed and you were in contact of a COVID patient, probably you are not going to get infection from him. Another aspect of this webinar is that the biggest fraternity, biggest section who are sacrificing their lives is doctors and medical staff. It was in the news that almost 2,000 medical professionals who are government servants contracted infection, and the death was almost 13, and all were related to medical professionals. So that is the state of affair. It is very important, rather it is a matter of paramount significance that we should treat our patient, but we should save ourselves as well. Now how? So incubation period is there, but how to recognize? Usual pattern is on first day a patient gets fever or chills, cough starts second day, but by third day usually in most of the cases fever disappears. Shortness of breath or difficulty in breathing is usually day 7. Fatigue, muscle or body aches, headache, and new loss of taste, agnosia or anosmia, sore throat, congestion or runny nose, GIT symptom, nausea, vomiting, or diarrhea. So there may be one or other symptoms during the illness that can happen. And if we have this knowledge, probably anybody in this period coming with fever, if we say that get your test done for COVID-19 RT-PCR, then there is 50% chance that he will turn out to be positive. So every fever case, we must suspect that it is COVID. Now, there are 4 types of usual presentation. More than half of the patients are asymptomatic. And second most common manifestation is respiratory. Third is musculoskeletal, and fourth is GIT. And at one of the time, initial stages of lockdown, when everybody was kept in hospital and every contact was tested for RT-PCR, then asymptomatics were as high as 80%. The second group is respiratory, and respiratory is one of the most dreaded because of the complications of pneumonia-like complications affecting both the lungs. Musculoskeletal, usually a patient gets body aches. That is most important. So that is next common. And few patients also complaints of diarrhea, vomiting, and nauseating feeling, and that is GIT. So these are 4 common manifestations and patterns of COVID disease prevailing in our country at the moment. And these symptoms a person during course of the disease may get at different times. In hospitalized patient, usually it is again not very common, it is not uncommon to find delayed complication, delayed presentation of fever and respiratory failure. We have seen in our RHL COVID hospital, couple of the patients who at the time of admission were okay, but after 6 or 7 days they deteriorated. They developed high-grade fever and respiratory failure. Non-hospitalized fever patients, usually common symptoms are fatigue, headache, muscle ache. So sore throat and nasal congestion, even rhinorrhea are also prominent symptoms, and anosmia appears to be most specific for COVID-19. If analogy, I am given opportunity to extrapolate analogy, then this is a pataka. So we can see that the COVID Symptoms are just igniting the fire. So gradually and slowly fire picks up this thread and then there is a blast. So normally in body these COVID symptoms are there, but if there are comorbid conditions and elderly, then it can blast and kill the patient. That is a sort of analogy. And if and whenever we get COVID report positive, the first and foremost question which comes in our mind is whether my disease will be mild or it will turn out to be serious. The simple thing, if we get couple of the tests done, then probably we can know. And among these tests to tell is CBC. If lymphopenia is there, eosinopenia is there, or neutrophilia is there, yes, that patient may have more severe disease. High CRP, LDH, serum ferritin, and FDP are important markers of ongoing inflammation and cytokine release syndrome. FDP and D dimer elevation indicate that there may be a probability of thrombotic type of complication, and in such scenario usually low molecular weight heparin or heparin is administered in hospitalized patients. D-dimer with lymphopenia probably indicates critical illness. Procalcitonin with elevated procalcitonin, we can differentiate bacterial from the viral illness, but in COVID also, first week procalcitonin is normal, but in second week this differentiating feature is lost. IL-6 is again a marker of severe inflammation, and if it is high, then couple of the medication can be advised to the patient. HRCT done at the end of first week is quite sensitive in picking up many infection which appears innocuous initially. Grade of severity of COVID are suggested mild to moderate indicates mild symptoms to mild pneumonia. Means less than 50% of lungs are involved. Severe means dyspnea, hypoxia, and more than 50% involvement. These patients are almost 14%. And critical, when respiratory failure, shock, and modes are present, it is almost 5% only. The course of the disease, as I said, first day usually fever and nose, cough, then patient feels better. And by the end of fifth week, he may develop dyspnea. And many usual complications occur from 5 to 10 days. But some patient may not develop dyspnea at the end of 5 days. So I call this period 3 to 7 honeymoon period. And many patients develop this sort of impression that their disease is cured. But the time of respiratory failure is at the end of first week and 7 to 10 days, and such patients sometimes may get complication of respiratory failure. Medical attention is if has not been drawn, then fatality may occur. So, however, one good thing is that now everybody is having oximeter. Even public is having oximeter. They are measuring it. At least COVID can be complemented that everybody is aware about respiratory failure. And in long run, not on in post-COVID era also, it will be very useful. Now, question is, who may die? It has statistics in Indian statistics shows if age is more than 80% and there is COVID illness, then 15% may die. 70 to 80, it is just half of that, that is 8%. 60 to 70, it is 4%. And in addition to age, if comorbid conditions like hypertension, coronary artery disease, diabetes, CKD, and cancer are there, there is possibility that patient may have severe disease. Interestingly, very interestingly and curiously, respiratory disease patients, usually TB patient, may have more COVID disease, but asthma and COPD are probably only very few patients are affected. It is interesting and to be investigated in future research. A word about RT-PCR. Suppose I am having symptoms, and with these occurrence of symptoms, RT-PCR is most important confirmatory test. Problem with RT-PCR is method of sampling, because there is big fear psychosis, and that fear psychosis affects even medical professionals also. So the person who collects sample is most important person. If he takes only mouth sample, oropharyngeal sample, then the accuracy of RT-PCR is only 40%. If he collects sample from nose and mouth, the accuracy is 70%. And then there is viral replication. It is said that CT number is there. So it is once there is some RT-PCR done, then usually multiplication of RNA take place. And after how many cycles of multiplication of RNA, the machine detects virus is important. If viral load is heavy, then earlier machine detects the load. If viral load is low, then machine has to exert more. It may be 35, 40. It does mean viral load is low. And sometimes it is only 18 or 19. It does mean viral load is high. One most dreaded complication of COVID disease is hypercoagulability, and it leads to increased risk of venous and arterial thrombosis of large and small vessels. And the predictors of hypercoagulability are mild thrombocytopenia, increased D-dimer level, increased fibrin degradation product, prolonged prothrombin time, and elevated D-dimer level have been strongly associated with greater risk of death. Deep venous thrombosis, pulmonary embolism, microvascular thrombosis of toes, clotting of catheter, myocardial infarction and injury with ST segment elevation and trophy elevation and large vessel stroke. So these are embolic complications which we come across during the COVID disease. What is the management? Friends, you will agree with me that it is placebo pandemic. Rightly, Dr. Rajiv Gupta has said and published article in New England Journal. All sort of placebo in name of energy boosters and energy drinks and energy sachet. Then there are vitamins, and then there are large number of medicines which are claimed to cure the disease, but none has evidence. We are all using empiric therapy, none has evidence. So no yes and no for, but there are supportive therapy. How can we save lives? Number one, early detection of disease, and then manage associated complications. Like if hypoxia is there, oxygen is can save lives. If hypotension is there, our therapy can prevent hypotension. Arrhythmia can be cured. Electrolyte disturbances can be corrected. Hyperglycemia is notorious in these patients. At our RHL COVID center, also we have found out that hyperglycemia is quite common. On one hand, COVID increases hyperglycemia. On the other hand, steroid which is used in cytokine release syndrome also causes hyperglycemia. Hydroxychloroquine, though was came out as a wonder drug, but it still needs lot of evidence. But my personal experience is that in musculoskeletal disease, it is sometimes it is good. Remdesivir, when inflammation is there, when CT chest shows some disease, and tocilizumab, when apart from cytokine storm, we also have increased high level of IL-6. Then these are